this afternoon, I am delighted to welcome Mac, or is it Max? I say that because Mac actually replied to me in a message while we were organising this, and signed off as Max. And then he commented that he'd been with the NHS for quite a long time. It's nearly 50 years, and said that the rumours that Nye Bevan was a friend was untrue. But I take that as true for Max, but I still think that Nye is actually sending Mac his best wishes for his last few months in the seat, the hot seat with the Mid and South Essex ICS.
Now, my first Secretary of State, Peter, was actually Barbara Castle, and when she arrived, yes, when she arrived, there are only black and white photos now, but she appeared at the Department of Health where I was working, and a friend of mine went to meet her at the car, and he said, "Secretary of State, what are your priorities?" She said, "The National Executive and my hair." And I met her in her dotage, and she was still beautifully coiffured. I think she was probably the first politician to recognise the importance of image on television once it had arrived.
I think it's fair to say in our lifetime she was a real pioneer for women breaking the glass ceiling, and was a force of nature, and a real character, and actually a very committed public servant. So, Mac, I will introduce you. Anthony, known as Mac, has more than 40 years' experience in the NHS and other healthcare organisations, most recently before joining the Mid and South Essex team as Director General for Health and Community Services for the States of Jersey. They obviously let you out. Originally a far-stream civil servant, Mac joined the NHS in 1987, operating for 25 years as a CEO, helping to turn around performance at several hospitals and commissioning organisations. Having established his own business, he served on the Future Forum in 2010 and returned to work in the NHS in 2015. And I'm personally very pleased that you were kind enough to come and join Mid and South Essex as you draw to a close of your glittering and illustrious career, because I've been very honoured to see you at work and know how much you contributed to us all, and it's not been an easy task, so thank you very much for your service.
I think the thing from my point of view, Peter, and thank you for those kind words, is I stayed because I'd met our chair, Professor Mike Thorne, a really great chair. And during COVID, when I had to put on a special hat and become Gold Commander for Health, I got a glimpse of the potential of this part of the NHS to really change its destiny and improve things for its patients. We were all pulling together. We achieved some amazing things, and I saw our potential to do that. I hope and believe that the Integrated Care Board that has been created last year can build on those opportunities, to build on that potential, and can genuinely make a difference in the way that we organise and deliver care locally. So that's what made me want to stay. Unfortunately, as you know, Peter, when I signed up, my wife moved house. So I commute 4 hours each week across 6 counties and live in a single nurse's room at the hospital in the week. So it's been quite a stretch for me for that reason. But I really do feel optimistic about healthcare in this part of the world.
Thank you for doing that. And please pass our thanks to your wife for her generosity. You and I were together this morning at a meeting of the Voluntary Community Faith and Social Enterprise Assembly for Mid and South Essex, which I've been privileged to be part of the construction of. And I think that you showed a very good understanding of the sector, and I know that you believe in its importance and have done from all the time you're here, and that's very refreshing. So we'll finish the mutual admiration bit.
Yeah.
And part on. So I'm going to start off by asking you a few questions. So how do you reflect on the 50 years of your NHS experience and the ups and downs of the NHS? And what do you think we should learn from the NHS's first 75 years, please?
Okay, so as I say, only been around for 50 of them, but this is my 5th set of major national reforms. And I think the reforms are what you make of them. When they come along with a set of national reforms, I tend to get my surfboard out, because if you get to the front of the reforms and take advantage of them, you can normally improve things for the area of the country that you work in. And that's what I believe the Integrated Care Board under Professor Mike Thorne's leadership, our chair, is setting about doing. We haven't made as much progress as I would have hoped across the 3 years because of the challenges of COVID and other things that we've dealt with. But we have created a strong platform to change things moving forward. We've got a new chief exec at the Acute Trust who's got a very strong record in dealing with the kinds of quality and other challenges that our hospitals face. We've built a strong team at the Integrated Care Board itself, and there is genuine cooperation now between all the partners in the NHS side of things. When I came, the 5 CCGs tended to pull in different directions, and they weren't always at one with the NHS providers. That has changed, and we're looking forward together. I guess the 75-year perspective is that the things that unite us are stronger than the things that separate us around healthcare. And I say that from the standpoint of a patient and a user of the NHS that myself and my family have used down the decades, because the engine that fires the NHS for me is the interaction between an individual clinician and a patient. That clinician knows they have all the resources of the NHS behind them when they have a sole focus on the person in front of them. And the person receiving care knows that that professional, he has trained for years, has joined their profession and is dedicated to doing good for patients like them. And that triggers an understandable and genuine appreciation of what is being done for them, because when it goes right, when it is done well, that makes every patient rightly feel special. And it is that loop that when things are working properly is the spark that drives the engine of the NHS. The things that come at us nationally, whether it be COVID or differences and disputes around pay, or rising expectations about what every part of the NHS can do, they're the things that pull us apart. But I think the cohesion between clinicians and patients and everybody committed to the NHS is much stronger, and it's what drives us forward. So that they would be my 2 perspectives, I think, Peter.
Thank you. One question, sort of follow-up question on that. Would you agree that the NHS that was started in 1948 was doing so in a rather different context to where we are today. If you were starting today, you wouldn't start from where we are. Last night, I watched an episode of Ambulance, which struck me quite strongly because there was a vivid presentation of a patient, someone who was homeless with mental health difficulties, and who the ambulance service and A&E, they couldn't find anyone who'd pick them up and give them support. And one of the things that I've been looking at is wondering, if we started today, what would the patients and service users want as the sort of foundations of 24/7, 365 service?
Okay. Great question, great challenge. So I'll turn that one around, if I may. I don't think we would be where we are today if it hadn't been for the way that we started out all of those years back. At its best, and when we get it right, the NHS is at its best when you need it most. I think in large measure, our problems and our shortcomings are in the routine support and treatment and care that we provide for chronic health problems, or for the way in which we work with the voluntary and the charitable sectors, for example, to prevent illness. So we started out to defeat those giants that fella that I didn't meet but had heard about, Bevan, had written about. And people, as I recall it from my grandparents, actually, were a bit like people in America, looking to rely on the NHS for the dread diseases and the catastrophic things that could happen to one in life. Just before I worked somewhere else, my wife had a traumatic brain injury. Now, that's not the sort of thing that anybody wants, but the NHS raised its game, and she's still with us. I'm not sure that she'll be glad to have me back with her when I stop the commute, but she's done very well. And that is down to the NHS at its best. I have to say that once she got through the life-threatening bits of that, the NHS struggled a bit with the rehab and some of those elements. And so I think that's the pattern that we see. Now, I've seen the programme Ambulance. I think it's filmed in the West Midlands. Of course, the West Midlands isn't as good as Essex. We all know that. But interestingly, I looked up the statistics for ambulance times just before I came here. And I have to say, last winter, when we were in the depths of our troubles, the ambulance response times were horrible. And nobody sought to defend the delays that we saw. But right now, last week, the Category 1 response times on average were 9 minutes against a standard of 7 minutes. Now, obviously, sometimes it'll be quicker than that and sometimes longer, but that is not the very quick service that most people expect or fear. The 90 out of every 100 people that had got a life-saving need were seen within 17 minutes, and the target there, if you like, was 15. So East Ambulance Service is doing very well with those life-threatening services. The Category 2 calls, again, the average time to get to a patient there was about half an hour. A little longer than the 18 minutes that we aspire to, but again, a sensible response time. I think the television programmes can sometimes highlight the worst of what the NHS does, and I'm pleased to say that when we were really struggling on the ambulance side of things last year, we've moved a long way forward since then. We've got a way to go, but those important things that, if you like, the front door of the NHS are going much better and much more in line with the standards we set ourselves. I've got a similar set of numbers for the way that ED departments are working in this part of the NHS. I mean, 2/3 of every patient that needs to go in hospital via an ED gets there within the 4-hour standard. We can always do better, but it's not as extreme as some of the statistics would have us believe.
I absolutely agree. And of course, I was always saying it was a systemic problem, and the poor old ambulance services and A&E were being the dustbin for everything. And there was more to it, as you know. I'm delighted to hear that you've had personal benefit from perhaps a major trauma scheme. Because, as you know, I'm heavily involved and have been from the beginning with our regional one, and they do marvellous work. And another series called Hospital has, from time to time, shown brilliant examples of the hundreds of people who are there to help people who have the most complex and awful trauma injuries. As you know, I'm a strong advocate for improving the rehabilitation side of things, and thank you for your help in getting MSE, Mid and South Essex, focusing on that aspect, which is really important. I've always been very impressed by the service that the military personnel get in cases of trauma, and I'd like to see a similar service for civilians as well. But that's another story. So yes, and it's very encouraging that things are improving in the way they are. So, given you're on the cusp of leaving, when you hand over to your successor, how do you think the NHS and the integrated care system stand today, particularly for us?
I think poised to really drive some further progress. So if you take the move away from hospitals to provide more care closer to home, in my view, we're better organised and more committed than ever before to getting that shift to happen. Now, the thing that's pulling in the other direction is that we've got very sizable and long queues for hospital operations. So that tends to quite rightly attract resource to the hospital end of things. But if you even take the emergency front door arrangements, now if you ring 111 in this part of the world, we've got a service called UCRT, Urgent Care Response Team, that is community-based and that can offer people alternatives to getting on an ambulance and being taken to hospital. They will go to the patient. Again, if you're discharged from hospital, we've got virtual wards now that bring the standard of care that you'd get in a hospital to your own home or indeed to a care home. So our ability to reach out and offer a wider range of services to people in the community that they used to be reliant on hospitals for has grown and is improving. The other development is the one that we spoke about this morning, the integrated neighbourhood teams. The GP surgeries have been through a hard time in COVID, but we've helped bolster their capacity by getting them 466 other staff that work alongside GP surgeries now. Not all of them are doctors. We've managed to find 17 young GPs who want to come in our part of the world because they can see that there is a good future here and that we are aspiring to deliver the standards of care that brought them into medicine. But the 466 people that work alongside GP practices are pharmacists and physiotherapists Some of them are paramedics. They're bringing a range of skills to GP surgeries that practices didn't used to have. And that gives primary care the option to stream people differently. So if somebody other than the GP can, for example, deal with an acute problem that somebody has, they don't have to see the GP. We're getting back towards the sorts of face-to-face levels with GPs that we had before COVID, but we've got a range of other options now. And the integrated neighbourhood teams that are springing up, if you like, between practices, have got a range of professionals that come together and offer services at home, and they begin to blend physical health and mental health. They begin to bring in the skills of the voluntary sector and the communities in which patients live. So again, social prescribing, getting people involved in community activities can be one way of dealing with physical problems that, if left neglected, will result in falls and people getting on an ambulance and being carted off to hospital. So those integrated neighbourhood teams, we're going to see 9 of them installed locally this autumn in November. We've got new hubs being developed at the moment to help people whose care is being transferred from a hospital back into their home setting or into their neighbourhood setting to activate all of the resources around those patients. Those are changes that the NHS has talked about for a long time, but hasn't been able to accomplish. It doesn't in any way reduce the scale of the challenge at the hospital end to reduce waiting lists and times, but it extends our reach, and I think therefore extends our ability to help.
I think it's very encouraging. I've probably been involved with the system since around 1999, so nothing like as long as you, but I've seen a few things. I can remember around about 2008, the whole plan was to improve primary and community services, and that you would only go to hospital if you were on death's door, and hence Broomfield's new build extension was cut down from 4 stories to 3. And if you think about the amazing advances that have happened just in that last 15 years in acute care, it has, I mean, in my lifetime, it's changed enormously. I remember the first heart transplant, etc. So I think we've lived through extraordinary times. It's been very exciting. Unfortunately, the investment that went into secondary and acute care wasn't matched in primary care for various reasons. Obviously, economic difficulties arose very quickly after the plan. And I think you're absolutely right. I think that integrated systems and approach offers us opportunities, and it's really good to see that the Mid and South Essex are seeing that it's in the primary and community care system that there's need for catching up. Yes. What you just described is just that. So I think ultimately we'll get there. Virtual wards and all that sort of stuff are really good, and obviously things have been delayed because of the pandemic, etc., and that's put additional pressures on. So I think that's very encouraging. So the final question of our main ones, and then I've got some sort of quick fire ones, is how do you see the future of local healthcare for Southwood and Ferrers? Its primary care network, its integrated neighbourhood team, and the positives and the challenges. What you're going out, you've always been quite fearless in calling the system to account. What do we need to watch for? What should we be doing? What should we be holding people to account about?
Well, I'll say it quietly. So if Dan Doherty and Kate Butcher are listening they won't think it's me. But holding alliances to account, that's the way forward, I think. You have, in my view, a great team at the Mid Essex Alliance, led by Dan Docherty and Kate Butcher. And it's no accident that I've put some of our best people very close to the ground, because the more that we can build from the ground up instead of from the sky down, the better off we will be. So I would encourage you to interact with the Alliance and get Dan and Kate to set their agenda by the things that you want. So there was an excellent piece of work done around the PCNs in the Dengie and South Woodham Ferrers. I know I've seen the report. I can't remember all of the detail of it, but a huge amount of work went into that report. And the authors actually pinpointed some really important themes, like access to healthcare. Now, those are the things that an alliance exists to address. But they can't always sort the bus services around particular places, which I know is a problem in Crouch Vale, but they are going to be much better than somebody in the sky like me to address issues of access to healthcare, whether that be in the GP surgeries, to the hospitals, or to mental health, or anywhere. So getting the alliances to work alongside the primary care networks, and my instruction to the alliances is support all of the primary care networks that are ambitious and wanting to go places for their patients. Leave the ones that are still thinking about it to have a quiet life next year. Let's go with the ones that really want to drive things. So the other thing that I think I'm right in recalling from the report in the Dengie was public involvement. And I was very impressed when I first came to see the young woman that was working in the Dengie. She was then assigned from Essex County Council. I've lost the name. It wasn't Nicola or Amanda. Her name did end in an A, may have been a Deborah, but we lost her to somewhere in Suffolk and northeast Essex, but we'll get her back. Somebody working so close to the ground that knew residents by name. She was so devoted to getting the best out of public services for local residents. That way lies success in my mind, and the alliances can make that happen at neighbourhood level and in places like South Woodham Ferrers and the Dengie. So that's what I'm hoping and expecting to see Kate Butcher, Dan Docherty and the rest of the team do with and for you. I'd just like to see you driving them to get the right priorities, and your report is a great start for that.
Well, thank you very much. You've answered the first question, which was your reflections on our academic report. I'm very impressed that you picked up so much from it. Thank you. And I hope that it can be a bit of an exemplar for other places. I was talking after today's meeting to the chap from the Essex Association of Local Councils.
Mike, yeah.
Yeah, a number of people over the years have commented that what we do in South Woodham is a bit of a model that could be used in other places that have obviously adapted to them. I mean, we do seem to be quite unique in the way we've done things, but I think the value is, and you'll be pleased to know that after a little break over the summer, I'm organising the next meeting of the leads from the PPGs. I made a note of what you said this morning. You're going to be getting a note from me about the practice in our PCN, which is digging itself into a silo. No, they're not in our area. No,
Oh,
this
my
one's in
apologies.
Mayland. But anyway, that's another story. But I will
Okay.
send it to you so you can use your, because they just don't respond. But yes, I think that's really good. And what I'm encouraged about is that there are some new staff that have come into our PCN since around about March, who are clearly enthusiastic. They're getting things done, and there's a genuineness about wanting to work together. So
Yes.
I think you're right. And
Well, we've even got dog trainers like Michelle that have joined the team at that end.
Michelle's very, very good. I've known Michelle.
Isn't she just?
Yeah, she's a real star. Okay, so I think that I suppose the other thing was if you've got any suggestions for what we might use the Warwick Medical School Masters Programme for in 2023-24, then
These are the young people that you have come and work alongside you.
That's right. Yeah, the master. We were very fortunate. Sakara from this year, who comes from Bermuda, she's now got a job working in Bermudan public health, and very impressive.
She wrote your Denji and Southwood and Ferrers
Yes,
report. Yes.
yes.
Yes. I shall have to go out and discuss that with her, perhaps in Bermuda at some point.
I'm sure you'd be very welcome. If you go, let me know, and I'll make sure I put you in touch with her. Yes. So yes, so it's something that I'm proud of, and I think there are opportunities. So as I say, I was talking to Mike this morning about possibly seeing if we can use that to look at other things. The other thing I was thinking about was this idea of what do the people of Southwood and Ferrers and the Dengie want to be available 24/7, 365.
That's a good one.
Because, as I say, I think, emergency mental health availability, etc., and a number of other things. And while we're talking about that, I just emphasise the importance of the public inquiry
Yes.
into exist. It's really important that we can resurrect the confidence of the patients and public in our mental
Yes.
service.
So let me just say a word or two about the mental health side of things. First of all, at local level, each primary care network in your part of the world now has a mental health practitioner working on the patch and filling in that gap between GP surgeries and integrated neighbourhood teams. Now, whenever you say 24/7, that really is an NHS thing, isn't it? Because the difference between a private hospital and an NHS hospital is you very well might find some senior doctors getting treated in a private hospital when they needed some healthcare themselves. But if they were seriously ill or had needs around trauma, you'll always find them in an NHS hospital because we're geared up to handle the worst of things and to handle them at all hours. Now, I don't know the extent to which at neighbourhood level we're going to be able to get 24/7 services in place, but crisis intervention in mental health has been with us for a good while now, and EPUT, like other provider organisations, has crisis intervention services. And I was looking only today, actually, at the support that they put around emergency departments, ordinary accident and emergency departments for people who turn up there and have a mental health need. And that, I guess, is part of the NHS seeing mental health and physical health as two sides of the one coin. EPUT has also established an emergency department for mental health. We haven't really got the messages out there very clearly that now exists in Basildon, but it does, and it offers a new route in. I think, though, your wider point about restoring public confidence in the EPUT services and mental health in this part of the world is a really important one. The original inquiry didn't get off to a great start. The public inquiry that has now been set in train, I think we're better prepared and better able to respond to the challenges that will rightly set to me and to Paul Scott and his team who run ePut. I think we'll be in a much better place to be able to provide the evidence that the inquiry will expect and want from us. But I guess, having been a turnaround chief exec myself in provider organisations, Paul Scott, who was like a breath of fresh air when he arrived at ePut, faced a very particular challenge. I remember in my youth playing cricket at those old mental health hospitals, those very large hospitals that used to be isolated and out in the wild, terrible places. But they had very deep set cultures. Very often there were generations of families that worked in those institutions. Now, down the years, the NHS has moved away, I'd say escaped from those problems. But community services, mental health services, and a few other areas of the NHS still have very settled teams with settled ways, working for long periods, even sometimes on the same wards. It's very easy, therefore, to get a culture that has grown up between a few people that have worked together for decades to dominate, and therefore changing that culture, as one of these people with a silly label on called a manager, can be very difficult. And I think Paul Scott's great challenge, and the challenge for the team around him, is to get from board to ward, to really get inside the way that people work and feel about their work in ePut, and to get all of the best of the NHS in its commitment to patients as individuals and to patients with mental health needs to the forefront of their mind all of the time. I remember.
Think you're absolutely right, Mac. I think that a lot of I think that mental health services have improved and are more 24/7 now. Coming back to something we were talking about earlier, I think there is a great need for communication about the NHS to the patients, and we talked about that a bit this morning. The other thing I would say is I think one of the great opportunities of the new integrated system is that it will drag social care into the same thing. You see, I mean, the NHS, you've had your community councils, you had Links, you had Health Watch. They're used to engagement, and there's a public element to it. You have public meetings where I can come along and ask silly questions, and there's transparency, although not everywhere, and with alliances, that's one of my hobby horses, but that's another question. But we need to bring the social care into that. And actually what I was really getting at from that ambulance example really was the lack of 24/7 availability to deal with things like the social care support side of people who are going through the medical side. So what does A&E do with them afterwards? What does the Mental Health Trust do with them when they've got to go back home and they need a support package, or or they're homeless and they need a hospital or whatever, that sort of stuff? And I think that's one of the big areas where 24/7 365 needs to come in. And if we can drag social care, social services into the same way, and educate and show them that it's an opportunity, not a threat.
So two aspects to that. On the emergency side of things, if a patient is going to be sectioned under the Mental Health Act, as you know, the social care social worker has to be part of that decision-making process. So they are present for that crisis heavy end of mental health. But where you were talking of people going home from ED, if you like to phrase it that way, people turn around in ED who wouldn't benefit from, the high-end physical health services that a hospital can offer. We're beginning to see that blend. Now, the NHS isn't ducking its responsibilities, but we are working much closer with the voluntary sector. So it's sometimes good to put support in place locally through the community that people come from. And if that can be engineered, it can be helpful. And I'm conscious that in Southend, for example, that's an arrangement that has worked well there. But what we have to do, as you rightly say, is make sure that social care is alongside them so that people aren't left with, if you like, just the voluntary sector supporting them, that social care is there as well. And in Southend, that's being done through a bridging scheme through the Southend discharge service, where they follow the patients in just the way that you describe. That's one of the bits of best practice that I guess we've got to spread out across the patch.
Excellent. Yes, it's good. I mean, I can remember when we split commissioning and service supply, etc. Integration, and everyone retreated to their silos, and everybody had their individual. I used to go round the public meetings of all the boards, and I felt I was the only person doing joined up. But anyway, I really do see integration as an opportunity, and we have to be fair and say it's only been going for a year around here. And I think you come with that vision, but you've had to start from ground zero. So a few particular things. What's the future of St. Peter's Hospital, and why? I just cannot understand why a tile hasn't fallen off and hit someone on the head yet.
Well, touch wood, it won't happen.
I agree.
Hopefully,
I'm not wanting it, but I mean, we've
yes.
been working on this for over 20 years. And
yes, and my sadness is that I'm responsible for extended delays in putting in place plans that would mean we don't have to rely on such old buildings. Now, just a few weeks back, thankfully there was no problems with the tiles, but there was water gushing through the ceiling, and we had to have the fire brigade out in the middle of the summer because we got a downpour and it burst through. The maternity service there has been struggling with its staffing for ever since I came, really, and they are intermittently having to close that service to strengthen midwifery care at the main consultant centres. So from my perspective, when I came as a newcomer, I could see that we had plans that were unfulfilled. Because we've got plans to do something new and better, the danger then is that the NHS doesn't put resource behind propping up what we've got. And forgive the pun in terms of buildings at the moment. So we've done the bare minimum in terms of maintenance and keeping the premises fit for their use. But we're going against the grain. So this summer, we looked at the prospects for keeping services going at St. Peter's across this winter. And our clinicians said that the risks were growing and that the prospects of doing well were diminishing. They also said that if we made a positive move, we could strengthen and enhance stroke care for patients that needed the rehabilitation elements of stroke care. St. Peter's has done a magnificent job. I met the staff there when they were displaced and worked at Braintree for a while during COVID. And they all said that the buildings were pretty awful, but you could see their commitment to patients shining through. So we're going to organise some moves this autumn to keep the services safe and sustainable for the future. We will then engage with what we call a pre-consultation business case, setting out all of the arguments and all of the figures about what it would cost to essentially rebuild St. Peter's and what the alternatives are and what our clinicians and what patients think about the options. And then we will come to the public and lay our case out to the public to say, this is how we see services developing going forward. And in my mind, on the basis of the paper world that I often live in, reading all of the documents, I think that we will be able to put a better plan together for the future of services in other locations, rather than just preserving the building or indeed rebuilding the building. That is all something that we will have to work at together over the next 15 or 18 months. In the meantime, we will take some temporary measures which are capable of being reversed to get us through this winter. What I've encouraged people to do is to bring forward the plans for re-providing those services at St. Peter's that have been forgotten about since before I got here. So there was a GP hub that was being developed around Heybridge. I've asked Dan and the team to make sure that we accelerate that. We've now funded a planning team to say, how and when can we get that GP hub built? And the timescales there, we're looking at 15 or 18 months to get that approved, on the way, funded and built. Now, if we can get that as the first brick in the wall, so to speak, of a development hub at Heybridge, that would be very worth progressing. We are looking to expedite, to accelerate that development, so that if the proposals do come forward that say we can't stay at St. Peter's forever, the facilities to replace the services that St. Peter's offers in outpatients, and outpatients will be unaffected by the changes that happen this autumn. They're only about the inpatient beds that are exposed to a lift breaking down, which is a safety issue for patients. The fire risks, the roof falling in, those sorts of things. So only inpatient services will be affected this winter. But longer term, we need to find ways of providing the outpatient care, the x-rays, the blood taking closer to home. And I'm looking at accelerating the schemes, not only in Heybridge, but also at Wick Hill, that would enable us to get closer to the ground, closer to where people live, and to offer alternatives in that way. So that's where we're up to.
Yeah. Two things. One, as you know, I'm a great advocate of best place, not nearest place. And you're moving a few things. All I always advocate then is please make sure that you've got the transport in place to enable people to make the journeys, and
yes,
right facilities at the place for people who've got to travel the distances.
And
but
I've specifically asked those looking at the changes this winter to examine exactly that, Peter, because you're absolutely right.
I think that message is getting through from the experience. I mean, it's like, you know, if you have to go to Addenbrooke's because you're a major trauma patient, we've got things in place like lounges for the people there. We've got them set up with local bed and breakfast places that they can send people to, all that sort of practical stuff. And obviously it varies. But yeah, you understand. I think all I'd say to you is there is a huge frustration. I've been on various working parties about the future of St. Peter's going back literally 20 years. And I fully understand the way that things develop, and that what you would put in place now will be very different to what you would have put in place before. It's just that we so often go through these steps. So, you know, if you could lay a brick or something before you go somewhere for Malden, you'd be famous in your
yes. own way. If I may, Peter, just one thing from my perspective. I utterly respect the commitment of that staff to the service that they have built up at St. Peter's. I know that anything that we bring forward by way of a change will be tremendously unpopular, and it will be unpopular for all the right reasons. I would just say, therefore, that I wouldn't propose a change lightly or without a need to do so. When you spoke earlier about stroke care, I was involved in consulting on some changes for the acute aspects of stroke care, the very early stages of when somebody has a stroke in South London. And we were taking services out of local hospitals and putting them into specialist centres, not just for rehabilitation, but for the first golden hours care for somebody who has a stroke. And in those public meetings, there was utter hostility to the changes, but people were picking up a different angle of the transport. They were saying it takes us an hour and 45 minutes through London traffic to get there, and the ambulances will be slow. The point that I had to make was, a very human version of the statistics. I said, it's not the journey there, it's whether you get a journey back. Because in the early parts of stroke care, the mortality rates and the death rates were so different when you were in a specialist centre. It was a bit like your trauma things.
Yeah.
Now, I'm not saying that it's directly comparable on the rehabilitation side, but specialist rehabilitation is a very particular form of NHS care. The people who've done it at St Peter's for so long do it really well.
Yeah.
It is the people, it is the care that we have to replicate, not the building.
Yeah, stroke's a beautiful example. I mean, I spent a lot of time looking at rehab in all respects, and neuro in particular. And stroke, I mean, it's come on leaps and bounds in terms of recovery rates and quality of life as it has. And that's where distance is not the problem, but you've just got to sort out the practicalities, because we've got to sell it. It's about communications again. So moving on, the future of the Burnham Medical Centre was something that was hotly discussed, and I know has been. I do wonder if anyone's, remembered the example of Crouchvale Medical Centre in South Woodham, and learnt any lessons from that. But anyway, I think
that's still going, isn't it, Peter?
Sorry?
Is Crouchvale the other one that's still going?
Oh, Crouchvale's the South Woodham New Medical Centre, which is
right. Yes.
I mean, I was always saying, we were lucky because during COVID we had the most modern infection protected place in the country, but it wasn't in the right place. But there we were.
No, I'm confusing it with Southminster, where there is still a process running on.
I was then going on to the new William Fisher Medical School postpone, Medical Centre postpone.
But you took me to Burnham, so I wasn't at the public meeting, but I saw the television pictures. I think we were a little bit at cross purposes. The GP practice was looking at its options for a move because of an increased list size. But actually, we weren't encouraging them to do that. We weren't taking decisions on moving them. The GP practice on our behalf needs to think about how it can respond to an increased list size and to look at its options in terms of its premises. I think the element of cross purposes is that the GP surgery and the GPs, if you like, as a separate business, were looking at their options. The NHS could work with them to look at those alternatives. But one of the things that the GPs and the NHS has to do is to make sure that if we make a move, it's one that's seen to be for the better. And I think there was a very clear signal from the public meeting that Sir John Whittingdale told me about, that actually we're a long way from a right answer right now. And, people will go away and look at decisions in the future against that backdrop.
Yes, and as I say, I do think that what happened in South Woodham in the lead up to 2019 is an exemplar, and there's a lot to be learned from that, because we have the benefit of a very good new facility, which everybody believes could have been better sited, but you've got to work around the social responsibility aspects of things. But again, if you've it was quite funny. Last Friday, we had the Tour of Britain go by, and in desperation, the poor policeman trying to control the traffic at the roundabout with the Sainsbury's Medical Centre had to finish up sending all the traffic into the Crouchvale and Sainsbury's car park. And as the 44-ton articulated lorries went in there, I was thinking, but you can't put them in there. We couldn't have a bus stop because there weren't sufficient foundations. The whole thing's going to collapse. It didn't, but so there are planning aspects. But I hope that there'll be learning. But again, it's about communication. So yes, William, again, we've got strong people saying, what on earth's happening with the postponement for the William Fisher Southminster situation?
Okay, so the GP surgery, and don't forget, we spoke this morning, these GP surgeries are small businesses in their own right. Some of them are not so small. I pay some GP surgeries more than £2 million a year. They're not like a corner shop. So they have to do planning about their own futures. I know that the GP surgery in Southminster was looking at alternatives. It got into some complications around planning approvals, I believe, which not of the NHS is making, but that are one of the hurdles that have to be overcome. So there was some delay there with the developer. The simple problem from the NHS angle is affordability. There is a national rule that every part of the NHS has to follow, and that is, if it costs more than the district valuer says it should, you're not allowed to pay for it. Now, the district valuer looked at the plans that had been developed for Southminster and said they should cost about 150,000. The developer has come up and said, we'd like a rental of about £250,000 a year. So I'm not allowed to pay what they are expecting. Essentially, those things can come down to, are we developing something that is above and beyond a reasonable expectation, or are district valuers behind the times? Normally, it's a bit of both. But there's a 100,000 a year gap there for 25 years. So if I was to pay you a mortgage that was wrong by 100,000 a year for 25 years, how much profit would you be in, and how much would I have lost out? And it's the same as that for the public purse, isn't it? I can't pay millions and millions of pounds extra over and above what the rules of the NHS nationally say a particular private business is entitled to charge for the premises it would like to use. 25 years times 100,000, awful lot of money.
And in the context of this morning, I'm conscious of the time. I don't wish to intrude on anything that you're doing. What time do you need to finish, Matt?
No, whenever suits you best. I can bore with the best of them.
I haven't got a lot more. David and Jackie, if you've got anything you want to chip in, let me know. I'll just plough on a little bit. Bradwell Power Station is looming.
I don't know anything about it directly, but when I asked, the message was unlikely to proceed. I don't know how reliable that information is, but that was the whisper in the crowd that I got.
Interesting. Yes. Yeah. Okay. That's where we are at the moment.
But the people I ask can be wrong as well as right. But that is honestly our view on it.
Yeah. And you've covered the bit. I mean, accessibility to services is an issue for our area. For the people on the Dengie, it's about the travelling distance, and the time it takes for ambulances to get to them, for them to get to the places like Broomfield, etc. I was interested to see that C360 has taken over the community transport, and I've actually seen a few of their buses, and it's on my list of things to do to contact them, because I think that they may be certainly a bit of a help for South Woodham. And I've also seen that our community care scheme is now not limiting itself just to taking people to hospital appointments, and has recognised that there is a demand or a request for people to be able to get to Crouch Vale from around the town, and that they are looking to expand their volunteers to do that. So I can see a bit of a chink of light for South Woodham, and I think we'll have to investigate the Dengie situation. David and Jackie, have you got anything you want to throw in at this stage? You're on mute.
We are aware we are on mute, but we're not anymore.
Well done.
We'd just like to thank you for all the time that you have given to us, and for a very interesting hour. Thank you very much indeed. And
That's
for someone
kind.
who's been on the periphery of the NHS for 60 years, but at a much, much lower level, it's very interesting.
Well, I certainly owe it to you, having let Peter down twice, neither for very good reason. The rest of my life crashed into my official job, and it was the official job that lost out previously. So I'm delighted to be with you tonight, and thank you for the opportunity.
Thank you.
Thank you very much.
We don't have anything special, Peter, for you.
Right, okay. I'll throw in a couple of things that came to me from this morning very briefly.
Yes.
One is, will the alliances have the skills, resources and experience to fulfil their roles in the communities with the cuts that have been made? Is one.
Yes, I've built up the alliances, not cut them back. The alliances will account for 25% of all of the people at the ICBs. The aim is to strengthen them, not to weaken them. Sometimes, you can strengthen something by streamlining it. There is no intention to reduce the impact and the efficiencies of the alliances. That they are the future as far as we're concerned. So we're not going to asset strip them. Frankly, we're expecting to see them step up, not just do more of the same.
Good. How significant is the King's Fund busted myth that the NHS is overmanaged to the organisational challenges at executive level by things like Lucy Letby and the Essex Mental Health Services? So
a very serious part to the Letby tragedy and the EPUT public inquiry. But just at a more prosaic level, you heard me this morning with my experience as somebody that gets sent in to fix different parts of the NHS that's gone wrong. Too little management, if anything. There's sometimes been too many managers with their fingers in a pie, but I don't think the accusation that the NHS is overmanaged is credible myself.
No, the King's Fund has busted that. I absolutely agree, because if you actually look at the figures comparatively,
yes,
we're actually undermanaged. So I think that's actually a tribute to the quality of management.
So one of the things that
management are coming under stress, and it seems to me that the examples of Lucy Letby and the Essex situation and one or two others that are bubbling around at the moment may suggest that the executive management in some organisations is not going about things in the right way.
I think when we come to things, the dreadful events surrounding Letby and the genuinely deep felt concerns around EPUT and its history, we're probably thinking more about leadership than the mechanics of management, because there are judgment calls that need to be made, and it's really important in a sector like healthcare that those calls are made correctly. For me, that takes us towards the importance of clinical leadership and clinicians and managers working closely together to get to the right answers. That has been one of the big themes of my time here. And what we've had follow the clinical commissioning groups that were superseded by the ICB. I've now got 40 odd clinicians whose day job it is to look after patients, focusing on individual service areas, and who are at the table informing decisions, giving their dissent, giving their warnings, speaking directly to people before judgments are made. Now, that's the sort of thing that will change the way that the NHS responds to different issues as they arise. I wouldn't think of giving a management response to an NHS problem without getting the input of a clinical leader who's given their life to that service. For me, the problem and the worrying part of the what we hear publicly so far about the Letby case is the failure to listen to clinical leaders in situ. Now, obviously, that can have its own difficulties, but my default position is to listen to the clinical leaders first, because my experience is that generally takes you to the right conclusion.
Very wise, very wise. Thank you. My last offering is, does the NHS Charter need revising to re-emphasise no decision about me without me, and to include the right to second opinions?
I go back to what I called the strength of the NHS. It's that individual relationship between a dedicated professional and clinician and the individual patient that they're caring for. Charters and strategies and policies are just the wrapping. They are intended to create a condition where the clinician knows that the organisation they work for also wants to do their best for that patient, that the clinician doesn't feel that they're the only one that wants to get it right for the patient, that they know the whole of the NHS is behind them, and that patient can feel empowered to say, well, thank you for doing what you can for me. I would like another view. You'll appreciate it's my life, it's my future that we're talking about. I'd like to hear somebody else's professional opinion. I really value what you've done for me, but let me have another view. If we raised a flag every morning or wore blue balloons or red balloons attached to our jackets and it improved that condition, I think it would help. I've seen a lot of charters in my time. I don't think the paperwork is what makes the difference. It's how we set that climate when a clinician and a patient are together. And it's alive and well in this part of the NHS, as best I can see. We need channels through which people can appeal and escalate concerns. And I hope that we have them. I hope that we'll strengthen them, and I hope that they'll be well used in future.
Okay, my observation would be I commend the Integrated Care Board for consulting about things in its time, in its first year. And I ask you to remind some of the people who are involved in the partnership, who are service providers, that that's where I think there's a need for a reminder. We're getting too many announcements about changes and everyone's saying, hold on a minute, where did that come from? And they're really not getting the patient involvement and voice at the beginning. And I think you and I will both appreciate that if we're active, we can actually help from the patients by thinking about things that others don't. And I think it's a missed opportunity.
So we're coming at it from the same place, but I would suggest that if one of the organisations does what what you describe, look at it as a failing on my part, because I won't take it badly. Let's look that somebody slipped past me, and then I can go and remind them. But we are trying to get everybody in the position where we want to consult and we recognise the importance and value of it. But when it doesn't happen, that's my responsibility to put it right. I've probably got more things wrong than I've got right since I've been here. It's the nature of the job, but it is the responsibility of the Integrated Care Board to make sure that the whole of the NHS gets that patient engagement, patient involvement, public consultation aspect right.
Well, thank you very much. As I say, my eyes lit up when I heard about ICPs, because I thought one stop for everything. So I should be able to ask you anything about any of the partners, and then
yes,
as the single point of contact, and then get back. And equally, I think that if they all put their comms through one place, it would help. But I appreciate that that's perhaps going to take a little bit of time.
Hopefully we'll get there.
Questions at this stage, you'll be very pleased to learn. I'm extremely grateful for you giving us this session, and for your candid honesty. And as I say, I can only end by thanking you very much for all you've done to get things up and running here, and wish you all the very, very best for your well-earned retirement, along with your wife and family.
And a new puppy.
Yeah, and your new puppy. Yes, I've got one on my foot at the moment. Yeah. And if you want to keep in touch, we will love to see you from time to time if you're ever open.
Three peeps on the whistle and I'll come running, Peter. Thank you so much for your time, and thank you for the opportunity to do this. I'm so sorry I let you down previously.
No.
Thank you. We will be ensuring that colleagues will be looking at the recording of this and taking note of all that you've said.
And I'll send it.
That's kind. Thank you, David.
And Kate as well, of course.
Super. Thank you.
All the best. Cheers. Thanks.
Cheers. Thank you.
Bye.
Bye.
Bye.